So welcome to NUR203 Pediatric Nursing. I am Professor Bogart. I am the lead pediatric professor for the RN program, and I'm very instrumental also in the PN program. So I work on both sides of the rainbow there, and I enjoy teaching, period. I have been a nurse since, listen to this, since 1976. I was a nurse at age 20, and I have worked almost everything. I have done adults, adult ER, adult ICU, open heart, surgical ICU, cardiac ICU, all adult. And then I went into pediatrics in the 90s. And my favorite is the cardiac intensive care unit for children that's congenital heart defects. We're going to go over that week 5. So I've got really good insight how to explain that to you to make it more simple, because I think it's the most confusing area for students. And I've also worked in the ER the last 10 years. So I've seen almost every diagnosis come in. And I also have a lot of experience in the newborn intensive care and PD ICU. So I've got stuff from all over the place, and I can actually help you relate your children to your adults and show you the differences and the similarities. What I did find, and I'm very unusual, not many nurses go into adults and change into pediatrics. I went from adult ICU into the newborn intensive care unit, and it was one of these. I did an agency job and fell in love with the babies and just learned it from the ground up just by experiences. So I know stuff from my adult world and how I can use it in the pediatric world, to help me better those outcomes. Also, the same thing, things that I learn in pediatric to adult, adult to pediatric, there are little tricks helping patients get better and not, as I say, going down the tubes, right? So I'm going to be sharing a lot of those things with you. I've been with Fortis since 2017. So I started at Cutler Bay. I started out teaching pharmacology and pediatrics. They asked me if I could teach pharmacology, and I went, well, I guess I can fake it. Well, let me tell you, it was more than I ever expected, but I did well at it. And I'm actually the dosage calculation queen. Now, I do not do ratio proportion. I don't understand it. But I can show you how to choose things from a formula to make it work for you. I'm going to be sending you some recordings. Anybody who needs one-to-one, I want no one to get any points off on dosage calc on any exam. I'm going to give you examples every exam. I'm going to work with you if you want it on one-to-one, or if you want me to maybe spend some class time at the end or after class, go over dosage calc. We can do whatever we need to get you there. Some of you are great, not a problem, but some of you do struggle, and I don't want you to struggle. I find math fun, and I will make it fun for you. Even those are like, ooh, math could never be. So what are we going to do today, and how do I teach? Well, I do a lecture, and I do a PowerPoint. I do not ever read a PowerPoint. I'm going to give you the overall gist. I'm going to explain the concepts on that PowerPoint. I'm going to give you nursing examples. Children I've taken care of, adults I've taken care of, and it will make a lot more sense when I do that for you. So I do that. When I'm done with lecture, I go right into a Kahoots. Now, Kahoots are an absolute godsend, I think, for you as students. You are being tested immediately on the information that I have just gone over. So I know students learn by repetition. So if you at least look at the information before you come to class, that's number one, that you've looked at it. Number two, I'm going to lecture it, go over things, answer any questions you want. You can always stop me. I'll never be upset. Raise your hand. It doesn't bother me at all. I will answer questions that you understand it. All right. And then the third thing, doing those Kahoots, that's the third time now that you're going to look at it. Now you've had it into your mind 3 times, and the memory will help. And you're going to hear my voice in exams, and you will hear my voice in the HESI, because I'm going to explain how things work. Up to this point, You're more of understanding knowledge. You're not taking the information and that critical thinking skill, the thing that you've learned, which means just applying knowledge. I'm going to show you how simple it is. And this is going to help you in your med surg too, which many of you are all in. And it's going to help you as you go forward into your capstone. So hopefully by the end of this quarter with me, I'm going to teach you how to think, and you're going to feel great about going into your capstone. And I'm always here one-to-one. Whatever you need, you let me know. So let's start. I've got 2 PowerPoints today. The first one I'm going to start with is going to be the orientation to online nursing. Anybody with any questions so far? Okie dokie. So what I want you to be very aware with online nursing is communication is number one. Tell me before something happens that something you can't get assignment in or you can't get to class, whatever it is. Let me know before. Supply documentation and you will always benefit from it. So again, tell me before and give me documentation. And that's what Dr. Brown wants, okay? Very important. I know life shows up. It shows up for me. So if something's happening, tell me as soon as you know. You all have my cell phone. It's in the modules, and I'm going to give it to you again. So online learning, we know it's hard. You're at home. You've got lots of distractions, and it's hard to focus. It's not like you're sitting in class and somebody's looking at you, right? Make sure that any questions, I answer things very quickly. I usually have my phone next to me. I'm always looking for messages, emails, and answering you pretty quickly. If I don't answer you quickly, send it again. Something happened, or I didn't see it, something. So that is something I always do pretty quickly. So any problems with online nursing, number one, you're going to contact me. Now, I am the lead, so there's no other person. Well, what if you are needing me and you can't get a hold of me for some crazy reason? Always contact Dr. Brown. Now, Dr. Brown, I don't get upset you calling her, asking her. I'm not going to be offended. I'm not going to be, upset with you. That's no. This is a team that I work with. I've been working with Dr. Brown since 2017. I know her well. She knows me. We both want the best and we both want you all to succeed. So, first of all, get a hold of me. You can't get a hold of me. You need something quick, then you need to contact Dr. Brown. Look at her email the way it is said here. It's not D Brown, it is Darlene.Brown. There is a D Brown somewhere, I think in Virginia. So make sure it's Darlene.Brown at fortiscollege.edu. And also there's her phone. I don't think the woman sleeps. She's up all night, all day. She lives on the West Coast. She's in Minnesota now, I believe she just moved to from Phoenix, just built a house there. So she's now in Wisconsin. But you know, she's here available. She's up early in the morning for those East Coast people. So do not be afraid. If you need her, something's going on, please contact. Now, when you're talking with us, please, as you're doing emails, try to be courteous, explain what's going on. Also, as I said, telling us before something happens, and then if something that you can get documentation for, get me documentation. If you're missing attendance because you had to run to the ER with your dog, your cat, your mother, your child, or whoever, because I've heard all of those things, please just send me something that shows that you went there with the date on it. And we could use those things to help not get you 20% attendance. These classes on Mondays, because of Labor Day, are starting at 2:30 till 5:15. And that is to put an extra time into an extra 15 minutes so that you do not have to make up class on Labor Day week, which is week 9. Now, week 9 is a quiz. I'm going to figure out when we're going to give the quiz. I'm not quite sure yet. because week 10 is an exam. So let's see what we'll do with that. And I'll figure something out and I will let you know all about that, okay? I have a question for all of you. You can have me stop, give you a break after PowerPoints before Kahoots of about 20 minutes. Or I can set up Kahoots, go straight through, don't give you a break, and I can get you out about 5 or 10 till 5 o'clock Eastern time. Would you rather get out earlier or would you rather take a break? You tell me, what do you want to do?
Get out earlier, please.
And don't mind if you have something to drink. I do not mind if you have to eat something, as long as you're courteous with it, okay? I understand you're students, you're busy, and there's a lot going on. Besides school, you have work, you have families, and many responsibilities. I get that. So I do not mind you having something to eat. I mean, many of you are getting out of work now and climbing into class, and it's lunchtime. Well, I don't mind, okay? Now, so that will tell you our class time. It's going to be somewhere right before 5 o'clock Eastern time that you will be done with class. One class might go longer, and that is week 5, only because it's respiratory cardiac and it is a full week of information. Can you imagine respiratory cardiac together? Those are the two big subjects, okay? So that's the one probably will go right there, but I will make every attempt to get you out that little bit early. Remember, there are all sorts of homeworks. I do remind you, I do send you reminders. There will be a week 1 information or week 2 information, and that's going to have what do you need to do. It's going to be right from the syllabus. What are the chapters that you have? What are the assignments? Do you have discussion board? Do you have a quiz that week? Do you have any other project due? All right. So I always put those out. I do put PowerPoints on there. Many of you do like to have them printed, copied, whatever you like. I do get them out early for you. I do, believe it or not, within an hour after class, you will have your recording and you will have the Kahoots that will be attached there afterwards. I highly suggest you look at the Kahoots and you review the Kahoots. You're going to see most concepts you need to know in those Kahoots. And I'm sure your peers have already told you about them. So make sure, that you do get in the habit of reviewing those things. Remember, the syllabus is your guide. It is when things are due. You're going to see, for instance, there is at the end of the course, about week 8 and week 10, I believe, these HESI case studies, the assignment exam, practice exam. You're going to see it open for one more week, okay? And that's because of the way I have to set up the program. It's going to be due week 8, but it's going to show until the following week, because that gives that one more week minus 10%. Okay, just to let you know there. Now, we've been in this online forum since COVID came in, and I was that person who went from campus into an online forum, when we had to, when COVID came. And there's been a lot of different things that have gone on, cheating, plagiarism, all of those things. And I just want you to know, if you're cheating yourself, because when you get to the NCLEX, you're not going to know the information and you're not going to pass the one test that you need to in order to become a registered nurse. So it's easier to get a C and just pass than to say, well, I need an A, so I'll cheat. An A does not make an RN. C equals RN too. And I had many students tell me, I'm a C equals an RN nurse. That's my GPA when I graduated nursing school. So it didn't make me less of a nurse. It just mean I just had to work really hard for it. All right. And yes, many years ago, but I had to work hard for it. Make sure that, you are going on the internet, finding these cheat sites. Be careful. They're looking at them. They are looking at them. making sure that you're not on them. So highly keep away from them. They can see you go in and out of them. So remember, ethical conduct is what we are. We're nursing, we're a profession, and trying to uphold those standards as being a nurse. This is some of those websites I was talking about: Studacco, Coursera, Stuvia, and there's a lot more of them. Those are just some that we're mentioning them. Please keep away from them. Don't copy and paste. That information will be flagged and you will be put up for plagiarism. If any of you are a repeat student, you cannot use what you used last quarter. You must change the words up, especially when it comes to the week 8 project. Okay. So if you're going to do the same subject, make sure that there's something called self plagiarism. You don't want to plagiarize yourself because that's still considered plagiarism, because everything goes through a plagiar checker and everything is recorded. So make sure you don't do that, because I'll send you a message telling you that you plagiarized, and I'm going to give you one chance to fix it. So we know all homework is due on Sunday night, 11:59 Eastern time, and it is due on that Sunday night. So if it's due week 1 by Sunday night, it's all done. If it's not done by Sunday, you are going to have one more week that you can turn it in, and that will be a 10% deduction on it. After 8 days, we will not accept any homework. Assignments there are finished, unless before these are all due, you've told me of extenuating circumstances. You were in the hospital, something happened. Let me know. We can work with you. But again, before things are due, let me know. One of the things that with attendance, we know that it's coming in, getting attendance. We know 1 minute late is 15 minutes. So make sure you're aware of that. 15 minutes, every class can add up, especially if you miss a complete class. It can get close to that 20%. So just be very careful with it, all right? Now, when you sign in, as I said before, put your name as known by Fortis, and you need to be on camera the whole time. Now, we used to have it pointing up at the ceiling, showing fans. And does that mean that you were at class? We don't know. And it's something that we have to be very strict with. Nobody in a car, sitting in a car, passenger or back seat. No, nothing in a car. That could be distractions to the driver. I've had students driving, want to be in class, and I cannot. What if something happens while you were in class and you're driving? Does that give Fortis responsibility for that accident? So that's why nobody in a car, all right? Another thing is we look at something in Canvas besides looking at just when you show up and those sort of things. We look at you documenting in the Canvas shell. You have to have 2 points of contact in the Canvas shell. Well, this week you've already have technology quizzes and all those things that you've done. Plus you have a discussion question, and you have to, by Wednesday, put your initial, and then by Sunday, you have to have 2 pair responses. So you've had already 3 times in there. You'll be good. Be careful trying to submit homework early, because maybe you will not submit your homework, something in the shell, and they'll look at it as what we call a 14-day no sort of documentation in Canvas, and they can drop you. They can just drop you all out of the course with no notification. So make sure you are documenting. And if you're doing the homework the way you should, there should be no problems with that. So I've already talked about it. It's 15 minutes for every 1 minute late. The first minute late, it's 15 minutes. 16 would be till 30. So that'd be 30 minutes late. So just be very careful with coming in. I do usually wait 2 minutes after the time. So I'll wait till 2:32 to start class, because I know internet and slow and buffering and that. but still, 1 minute late is considered 15 minutes. Again, with this absenteeism, if it's something due to a medical problem, something happened, give me documentation. And if you know beforehand, send me a message. Now you've documented your reason, okay? And you did it before. You're going to receive letters for it as it goes, 5, 10, and 15%. So be aware. And if you're not sending me documentation and why you're not showing up, you can get a full letter grade deduction from an A to a B, from B to a C to a D. And there is nothing we can do about that with no documentation. As I said, how to succeed, make sure you read your rubric and just read my announcement every week. It tells you what's due and what you can do, all right? Make sure your assignments get done. Make sure you do the assignments and get at least a 78 on them because that 20% can pull your grade down, okay? So I highly suggest that. Always try to get your assignments on time. I'm going to send you little reminders as we go through. Any questions with assignments? Send me a message. I'll talk to you. I'll let you know. All right. So make sure that you've gone through and you've done all your Canvas stuff and that you have, with the Canvas stuff, that you have know that what's due, when you're going to do those things. And again, your course syllabus is there. Come to class prepared, go to class, and then we're going to do our Kahoots, and we're going to have a really good time with Kahoots. Let me see who wants to win every week here. If something's happening and let's say your assignments aren't going in correctly, remember there is a help desk on your home page, technical support, let me know. If, for instance, you're doing a quiz or an exam with me on Zoom, immediately, if you're having problems, let me know. There's a way with quizzes and exams, I can say exactly where you were and what was going on. If you were connected to internet or if not, I can see all those little clicks that you've done. So let me know, and then we could restart your quiz or restart your exam. Don't try to go forward if you're having issues. Now, I do reviews whenever you want. I don't do, every week I'll do a review. Now, Professor Morris does them twice a week. If you want to go to one of hers, I mean, it's a different style of teaching, but it's the same concepts if you want to do that. If you are going over things and not understanding, I will meet you before, after class, or I will meet you during the week when it's good for you and that I'm not working or anything, okay? So that is, how I will tutor you. If you are a reentry student, you must meet with me weekly. So send me a message, okay? And that's tutoring. Tutoring, you will see your grades do better. And it's because you are, again, hearing the information again. That's the fourth time that I have personally, you done it before you came in with class, with the Kahoots, and now I'm going over it again. And it does make a difference and your grades will be better. So this is just your list of assignments. This is right off the syllabus. Unit exams, quizzes, HESI are 80%. Your homework is 20%. Remember, homework can fail you. I did have a homework fail this last quarter, and it upsets me that somebody would fail that they didn't do their homework and they had it 80 something in the class. So I think that's sad. But homework is important because I can't teach everything. And these little assignments give you all that extra stuff that you do need. Homework grades are turned off, and on week 6, homework grades are turned on. Usually a student will remind me, week 6, please turn on the homework grades. So if I haven't turned them on, somebody please remind me because you're my Monday group. On week they get turned off, and then they won't be turned on until after the HESI, after remediation, and that will be your final grade. So again, your KGA must be 78, and in homework must be 78, and then you will pass. When you come in for exams and quizzes, I have you come in only on your computers for your quizzes. I do a quick overall look at you. Okay, I'm going to look at your ears. I'm going to have no blurs. I'm going to look at your wrists, make sure there's no, watch phones on, and going to be recording the quiz for you. Again, there's new quizzes this quarter. So again, trying to keep the quizzes, the rigor and with them so that they still are good questions. Quizzes will be at the beginning of the class and it will be on the week before's information. What does that mean? Next week, you will have first thing, come in, we will take a quiz and it will be on this week's information. So you can look over the PowerPoint, you can look over the Kahoots that I give you, and there'll be 10 questions. You can only go forward, and they're 15 minutes, 10 questions. Anybody who has accommodations, I need to know as soon as possible because I'm going to have to set your quizzes up with more time, and we got to plan for your exams, how we're going to do them. Yes, Alea.
Do you allow us to take our quizzes like at campus with a proxy?
The quizzes are just here
I mean,
on
not,
Zoom.
I'm sorry.
Exam, okay.
Yes.
You can take an exam on campus if, number one, you tell me you're going to do that 3 days before the exam, and the person giving that exam, proctoring it, sends me an email. And then I can send that person the access code.
Okay, thank
You
you.
can do it around the same time, it is better because I'll be making up 4 different exams if that many students want it at a different time. So just let me know and follow those rules. And I do not mind you being proctored on campus. I know sometimes it's better than you on Zoom, whatever you'd like to do. Thank you. It was a very good question. Quizzes cannot be made up for any reason. We used to make them up, and we cannot do that anymore. It's part of accreditation thing. So we cannot make them up. Remember, exams are through ExamSoft. You cannot download an exam until 1 hour prior to the exam. Some students like to do it at the beginning of the week. No, 1 hour prior to the exam. Make sure with those exams, you come in on another device, set up the Zoom. I'm going to do a once over with you, and then you have your computers for just your exam. Once your exam is done, you can sign off on your phones and sign back into Zoom for class, and I will tell you what time they'll come back on that. Exams is only one attempt. You can't make them up. And again, something's going on. Computer's not working right. Or you didn't remember your charge cable and you don't have a charger and it shuts off. Immediately let me know. Okay. I mean, I would hope you'd have your charge cables. I've had some students do that. Or I've had all of a sudden inclement weather, especially during the winter with wind and snow and ice and all that. So I mean, it's summer, but it doesn't mean there couldn't be storms. Again, all about accommodations. I need to know. Again, um, what you were saying, Alea, about having exams on uh, ground. I do not mind at all. There's some campuses I work very closely with. When you're doing exams, one of the things is I will be doing a 360 around. I'll be looking at your ears. I'll be looking at your wrists. I'll be making sure that, your area is safe. Okay. And then I set you up with a side view and we'll go over that when we get there. If you're going to miss an exam, again, tell me before the exam is given, or it's going to be a minus 10% deduction. Okay. Tell me before. Send me an email before, and I've got a timestamp. I had to run to the ER, or my child this, or my mother this, or whatever. Let me know I can't take it, and we will rearrange either to join another class or I will pick another time to do it with you one-to-one. Let me know.
I'm a student from Cookville.
Yes, that we're just getting put into your class.
Oh, let me see
Okay.
how I do it on the phone. I can know how to do it in the
I hear.
computer.
Is that Steve?
Yeah. Hey,
Hi,
Betty. How
Steve.
are you?
Oh, I'm
Oh, it's
sorry.
just
I
me.
didn't mute myself.
It's okay.
Here.
I knew the
Sorry.
voice.
Yeah. Hey, Betty.
Yes, my dear.
We had a group of students. Well, actually, all of our students got put in the wrong the wrong class, and we kept saying, "Hey, they can't do that because they're in either clinicals or something else was happening." So we just put them all into your class,
Oh,
and
go
so
figure. Cookville to
so
me. I know that.
right, because I said
Yeah.
as soon as Betty or Wendy said, "Oh, there's 9 spots in Betty Booker," I said, "Oh no, that's the one we want. That's what I want." So anyway,
This is Dean Litterall. For those people who don't know, he is from Cookville.
they're trying to get on. So I've been looking, and I've got on. I finally found
The
the
Zoom.
Zoom link to get into there. So I they're going to be late, but we're going to try and find all of them and have them
Just
to
send them
meet with
in.
you.
I'm just going over that first PowerPoint regarding the rules of online. I haven't even gone into first day's class, so they're okay. They haven't missed anything. And you know me, I have a YouTube channel. Everything is documented. They can look at any recording they want. So the
I
information.
know you're awesome. They're just worried about their attendance is all.
It's first day, we expect it.
Unfortunately, right?
Yeah, yeah. All right.
So, okay,
Thank
just letting
you.
you know.
Thank you, Dean. All right.
Let me see if I can.
Okay. Let me put you on mute so we can there. All right. Sorry for the disturbance there, but that's first day of class, trying to get to class and getting information. So as we know that if you're not taking your exam on the time, make sure that I know before and we will arrange it. Again, if you do that, something happens, you have to take it before next class. So this is Monday. That means, by Friday, you'd have to make it up, or earlier Monday morning, make it up for that it will be over 7 days. Okay. Again, tell me before, don't tell me after. Again, quizzes are all in Canvas. It'll say quiz one, you click on it. Again, any problems, any technical problems, let me know. Sometimes it's internet's going on. HESI, it is one chance only that you have on it. Now, I want you to know even I just did all of the statistical data for the HESI last term on all the campuses, and my mean is greater than 900 on HESIs. I've got some great information. Use your Kahoots. I have Kahoots for the HESI, 2 100-word, 100-question ones, and I've got a great Q&A that I do right before the Saturday before that HESI, and it really does, again, help you to think. So HESIs, I can help you with it. Got to get through that first 3 exams, right? And of course, we know remediation, and I will put that into announcements for you. Make sure that when you come to exams, you have an ID or your license. Those are both fines. Again, if you need me, let me know. Homework, as I said, it will always be there in the announcements, what's due. I will always go over it in class. I mean, all we have is a discussion question and all the beginning works for getting into Canvas for this first week. And remember, prepare for week 2 quiz. Again, we know late work policy and questions. Now, I don't have a start date on NCLEX, which means you can do them. Some students like to work a little bit ahead. I would tell you you really shouldn't. And the reason is those NCLEX questions are preparing you for the exam. It's getting you used to the concepts that are going to be on it. I know some of you, you're on such tight schedules and, it's the only way you can get all the work done. Just make sure you don't submit it too early so you don't have 2 points of documentation on Canvas every week, okay? So NCLEX questions are like that, and your discussion questions are like that. There's no start dates. CJ Sims, I cannot open those, all right? And the other one that's open is the project, which is week 8. NCLEX questions must be submitted properly. It can't be that little green square. It must be, it's about 8 pages long, some of them. It will have your name on top and it will have your grade. The first NCLEX questions you do, be careful. It is not under pediatrics. It's under growth and development. And you click all of the areas, or you're going to say there's not enough questions, okay? Be careful on those first set. If the first set comes in and you didn't do pediatrics, the growth and development, or you submit them wrong, you will see a 0 in your grade. You can still turn it in and still get full credit, as long as you do it by the end of that second week, okay? So I do give you grace with that. Make sure your NCLEX questions are a 78 or higher. It's 5% of your grade. Those 4 NCLEX questions are 5%. It's quite a bit. So make sure you get at least a passing on it. The practice exams I was talking about earlier, or the assignment exams, make sure that these, again, hold on.
Come here.
Okay. The assignment and practice exams, again, make sure you look at the due dates on these because it is open 1 week later than that, okay? And those grades should automatically go over into the grade book. Those 2 assignments, the HESI practice and HESI assignment exams, they should go right into your grade book. CJ Sims, those are only open the week that they're due and 1 week after. What I've been told, if you do the CJ Sims properly, understand it, look up words, medications you don't know, it really helps with the HESI in the end, okay? So if you do it that way and don't just write down all the answers, you'll be doing better. There is one paper type project exam, and it's week 8. It is 6% of your total grade. It's worth a lot. It's when you're going to choose a diagnosis. Pick a diagnosis on something that's on children. And you're going to tell me a little 250-word APA paper about it. Tell me about what this diagnosis is. Then on module 8, you're going to see an assessment worksheet, print it out, and then you could take and circle all the answers. And in the end, it's going to be NANDAs and some theorists there. Make sure it's filled out. And then the third thing is going to be a teaching. The teaching could be either a PowerPoint, 6, 7 slides, don't have to be a lot. I don't need 30 of them. A brochure or a picture board. And just tell me something about that teaching. It could be how to give an inhaler. It could be how to keep an ADHD child organized. Some organization using a blackboard. Could be talking about cystic fibrosis, how to give respiratory treatment, CPT. These things are all teaching of any diagnosis. So this is an assignment that's open today. You're going to hear me tell you all quarter long, figure out some sort of diagnosis, something you had, your child had, your neighbor had, your sister, somebody you knew in school, something that you just always wanted to know more about. Make it interesting to you and start by just doing the paper. If you send it in piece by piece, I will grade it and tell you how to increase your grade to get that perfect 100. And you will get that perfect 100 if you do what I tell you, okay? Another thing, it is APA. Make sure that there are references, and a paper like this should have at least 3 references on it, okay? Tell me where you get this stuff from. The discussion questions have to have references on it. And some of you did already start your discussion questions. It is a two-part. It's all about nutrition and infants and nutrition and children. So you told me about yourself. I need to know about the nutrition and I need a reference on it, okay? And know how to cite your references in the body of the paragraph. If you don't know, let me know. I can show you so easily. It is not a big deal. And there, of course, there's a rubric. Use your all sorts of your scholarly information for it, and these questions, and this is the way that Dr. Brown and I think. If you missed an assignment and didn't get it done, even with a reminder, you will get a 0. But we look at it as you missed a treatment on a patient that you didn't get done. So this is the way that we try to look at what we're giving you to do in homework, etc. Right? As in, if something can't be done, you're going to notify the physician, right? If you can't get to class, you're going to notify the professor. So those are things very important. If you can't come, let me know before. If you have documentation, give me documentation. Now, we did get some students that had incredible grades on their HESIs, 11 and 1200s on their HESI. And it's very easily done as long as you do what I tell you to do, right? Now, this is what one of the professors did. And she did her CJ Sims and really looked them up. And she also did the NCLEX questions and really went through them to understand them, just didn't just do them to get them done. Okay? She understood it. And then went and asked the professor for what quiz questions she got wrong, what exam questions, so that she knew where her weaknesses were. And this student came out in 1145 and got a 99.99 on her HESI. And you're going to say, well, I'm never going to get that. Well, I've had students that are barely passing. They're 78, 77, 76s, and they get 99.99 on the HESI because they do what I tell them to do. All right? I will give you the information you need. You've just got to study it, okay? So that is just the first part. You're going to hear this in every class. I think that what you're hearing, the biggest thing is communicate before something's late or before you're missing something. And then if you got documentation, send it no matter what it is. I've had pictures of things sent to me. The kid fell down and scraped his knee and you see this big bruised knee. I mean, whatever it is, it can help. All right. Any questions? So welcome, Cookville. Glad you came. Don't worry, you're going to get a recording and you're going to get all the information you missed. And that's just the beginning of it. Any questions so far, anybody? We're going to go over now and let's go into all these chapters, right? Anybody look at how many chapters are for week 1? It's overwhelming. It's chapters 26, 27, 28, 29, and 30. It's 5 chapters, but it's like this overview. So healthy care, healthy people. Now, when I went back to nursing school, it wasn't that long ago. And I went back for my BSN, MSN, and my PhD back in 2008. And they had me writing papers. BSN is paper, paper, paper. And your MSN, paper, paper, paper. And a lot of papers work with these topics that come directly from healthy people. Healthy people is this government thing that they try to focus on certain things, whether it is nutrition, oral health, whether it's healthy weights, you've seen reading books. I mean, every president's wife has something they look at, don't they? I mean, Michelle Obama's all about getting out and playing, right? Getting out and exercising. And then some of them are all about reading and getting a book. Well, these are things you're going to see. In fact, you could go here and look for something for your pediatric assignment. Some of the problems with children that we are going to look at a little bit more is obesity and type 2 diabetes. I think that's on the rise today. I think a lot has to do with fast foods, processed foods. That's easier. Uh, every parent has to work today, and two parents have to work, and either just to make two pennies that, to push together at the end of a paycheck. And that's just the way it is. So you'll have to do what you have to do to feed your children, and sometimes could there be better choices? Well, it's what you have to feed them. Childhood injuries. Oh, kids are always unintentional injuries. Kids are always falling down and bumping and bruising everything. We know they're violence. We know that could be that child who is, the adolescent, or it could be violence, bullying, etc. Vaping has become something, but they're getting more information about that. And children do have mental health problems. You'd be really surprised. Infant mortality. I mention this because the United States is not number one in the least amount of infant deaths, really. One of the things that the United States is working on is things that we can do that can help that first year of life to have more infants survive, okay? The United States lags behind a lot of places. Switzerland is one of the big ones. That's one of the best of all. And we know a lot of the problems has to do with prenatal care, and we know it has to do with that premature infant, that low birth weight or that very low birth weight child. Those children are going to have some more problems. As they get a little bit older, death rates for children older do decrease. We know that when you now get into adolescence, though, it gets more because adolescents now, they try to do things. They become brave. They're getting their driver's license, and they're jumping on cars and being on the outside of the car and winging around parking lots, and I can touch daddy's gun now, and all of these things all happen because they have no boundaries in their mind. They think they're adults now, and it can happen. All of these injuries. That's why those mortalities increase as adolescents. We know homeless people in poverty. Of course, I've already said that low birth weight. Kids with chronic illness. Could be that kid who was premature and who has chronic lung conditions. Could be that kid with a cardiac condition, a congenital cardiac defect. All of these things can cause increased mortality. I mean, that picture just says it all. Guns, suffocation, swimming, burns, and of course, finding some pills and eating them. One of the things about pediatrics, and it turns a lot of nurses off, is because it's family centered. So you're not only just taking care of the child, you're taking care of the parents. And sometimes parents can be very difficult. Now, I always had a knack with parents. What I found out with parents is they just want to know what's going on, and they want to know that you understand what's going on. So the thing with family-centered care, remember, this is the constant. This is all the family knows, all right? So this is the constant in their life. And remember, family for me is different than family for you. The family is whatever they say it is. It could be grandma, daughter, and child. It could be grandma, grandpa with, their sibling's child. It could be two women. It could be two men. It could be, big groups of family in one home. It's a family. Whatever the family is, it is what it is. The pediatric nurse, as I said, you're not just dealing with the child, you got to work with that family also. Remember, you are going to be that, therapeutic person. You're going to be the person who listens. You're going to be teaching them. And that teaching is exactly what they need: disease prevention, health promotion, and of course, injury prevention. Children are afraid of needles and being hurt, aren't they? My dissertation is on school-age children's attitude and behavior towards injections. Now, injections is needles, and children don't want it. So what do we promote now in pediatrics? It's what we call atraumatic care. So as much as possible, we're going to numb. We're going to have a parent hold the child during stressful situations. And this is going to decrease their stress, their pain, emotions, everything. So we're going to decrease as much of the stress as we can. Now let's look at family. Well, I've already mentioned what family is. It's whatever it is. We have traditional and nuclear and blended, extended, and all of those. And then it goes on and on. There's all sorts of family. We know that the nurse is going to be that teacher. It's going to be there to know who the strengths in that family is and, how to help them take care of their child, especially like special needs children, right? We know that sociocultural influences the family, your culture, where you're raised, whether it's in a church, whether it's in a commune. I mean, I live in a place where there are a lot of they come in and they're picking all of our vegetables, right? And they have their own little communes. And I find they believe more in herbal medicines and whatnot. And all of these things you need to know about your community so that you know how to take care of these people. We know whatever schools they're into, we know their peers, all of this stuff influences children. I mean, today I have a 7-year-old grandson. You're going to hear about him all semester long because he's a really good example. But this is a 7-year-old kid who already is on social media, who is already telling me he's going to be a YouTuber. He's already looking at YouTube videos. He is so influenced by this stuff. And I know that other children are. And we have to be understanding of that. We know it has a lot of bearing on the race, ethnicity, the poverty, the education. All of these things is going to pay. You have to think about when you're taking care of these children. Just think about their religion. Do they need private time that you need to let them alone? Do they need to do some practices with that child? I've seen so many different things with it, but just giving them the opportunity to be themselves. So, what do you think a frequent health problem of migrant children and adolescents in the United States is going to be?
D.
You said B?
No, cardiovascular issues, diseases. It's my guess.
Tuberculosis.
I would say oh yeah, tuberculosis.
There it is, right there on the bottom. Tuberculosis is something that we in the United States, we tend to work with really well, don't we? We do all of our checkups and everything about it. So it is tuberculosis. So cultural beliefs, I'm telling you that this makes a difference, right? So for instance, what if you get somebody who has, let's say from the Middle East, and they're in their clothing and their headdress, etc., and they believe in covering because it's private, their skin, right? Would you take and just undress them to do a treatment? No, you're going to just that little piece of whatever you need open, you're going to have that open, right? What if there's special medicines or herbs? My husband is Jamaican. He believes in ginger. He believes in garlic. Now, this is okay, like these teas that he drinks. But remember, G, doesn't that prolong bleeding? Okay, could that create a problem in medical? Yes, it can. So again, it's understanding your community. It's also understanding there are people who need to pray 6 times a day, or they need to pray before they eat, or whatever it is, you need to be aware and give these families and children the opportunity to do what they normally do, because this is what makes them feel healthy. I know in South Florida, the one thing I didn't understand, I had some friends that were Dominican, and they believed if they had wet hair, they couldn't go to bed with wet hair because they'd be sick. Or if they had wet hair and they went outside, they'd be sick. Or if they got rained on and went inside, they'd be sick. And I'm like, I don't understand that. You just dry your hair off, take a blow dryer, whatever. But these are real beliefs that they really believe. Another thing I found out is there are cultures. Now, my children are half Cuban, so I'm also have the Cuban influence in me. And it is grandma telling the children to put socks on their feet in the house because cold feet on tile floor can cause them to be sick. And I tell abuela, grandmother, take those socks off when they have a fever because it draws the fever out and helps them feel better. So again, hot and cold are huge things. And I found in many different ways. I've seen voodoo witchcraft. I've seen them do all different things. If long as it does not interfere with your medical care, why not? Right? If it doesn't interfere and it makes that patient and that family feel better, it's fine. What about you get the sick child in and we don't know if they're going to live? Well, baptizing might be something they want to do. What about Jehovah's Witness and giving blood? Now, I've done it many times in my career. I worked at a really big pediatric hospital here in Miami, and many times in the ICUs, we had to give blood, especially in the newborn ICU and the cardiac ICU. And we get court orders for it because they will not sign. They feel that giving blood gives the soul from somebody else to your child or to them. That's what they believe, or that's what I think that they're influencing to me. Anyway, I've had to give blood on the night shift and on the day shift. At night, I wait till the parents go home. I have nothing left up when they come in there in the morning, so they know it's been done. I tell them to call me at what time at night, and I tell them it's finished. There's been no problems. Your child did well. During the day, I would have them leave the room. I would pull curtains. I would hang whatever I needed to and get the blood going, and I covered it with blankets. And I'm not going to leave the blood bag sitting there. Nothing there that showed it to them. And I've had people many years later come to me and thank me for respecting them and not putting the blood in their face. They know the child needs it, but they don't need to see it. Okay? They know they're getting it, but they don't need that. And again, those natural remedies, those things, those teas, you got to know what they are because again, they can make a problem with just what's going on with that child. Again, pediatric nurses, we're the biggest counselors there are. We're the marriage counselors, we're the child counselor, we're the psychologists. We're there to teach and to support. So, leading cause of death from African American boys ages 15 to 19. Remember, this is where the injuries go back up again at that stage, right? So, what would it be? Well, it's going to be your firearms. Absolutely, your firearms. But remember, as we go forward and start learning about adolescence, the big thing about adolescence is their identity, their body images. And many of them commit suicide. This is a high level of suicide area of children is your adolescence because they don't like what they look like. So, growing and developing. Now, I think one of the hardest things to remember in pediatrics is the first year of life and all the things that happen to them, right? And they grow, they develop, they mature, they become all different looking, and it's interrelated, simultaneous, and ongoing. Think about this. An infant's born at 7 pounds. By 6 months, they've doubled their weight. They've grown 1 inch every month up till 6 months. And by 1 year, they've tripled their birth weight. They've gone from not lifting their head at birth to walking or attempting steps at 1 year old. Is that like quick or what? And that's what kids do. And it's trying to remember all of those steps, which are difficult. So these are just what all of those definitions mean. Now, there are stages of development, And there's different terms that we use. You know, directional trend is how they grow up. Sequential is that you lift your head first, right? Then they turn over from their belly to their back to their belly. Then they get up on their knees and they start to crawl. And then, of course, backwards first and then forward. Then they get up and they creep and then they start to walk. And by 8 months, they're sitting up by themselves. This is that sequence, what they have to do. And then there's milestones. Well, we know a developmental pace or a milestone would be these children, most children by 8 months old, should be able to sit unsupported. Well, if it's 12 months and this child cannot sit, there's a problem, right? And these are the reasons why we know these little milestones so that we can, as nurses and medical professionals, figure it out. You know, what do we need to do? And you'd be surprised. And why I love children so much is they catch up quick. And we do what we call early intervention. Early intervention could be physical therapy, occupational therapy, speech therapy, and these children catch up so quick. It's quite amazing. And those sensitive periods are those periods where they just sit there for a while. We'll see those as we go along. Metabolism, temperature, sleep, and rest. Well, I sent you all on the first announcement is NUR203, Welcome to Pediatric Nursing. And it was talking about vital signs. It's an attachment that's there. Now, you know what an adult heart rate is normal, right? 60 to 100, that's easy. Well, a newborn, a neonate, that first month of life, their heart rate's 140 to 160. Their respiratory rate is 40 to 60. Why do you need to know that? Well, what if you were to give digoxin to a neonate, which is very common in the cardiac, program, a young infant to get digoxin? You'd have to know what a normal heart rate was, right? If they're a year old, what is a normal heart rate? What's too high? What's too low? If it's too high, is it volume depletion? Is it a fever? What's going on? Is it pain, right? So you need to know vital sign, those little bit route where they're going to be. So take a look at that handout. It's one I found on the internet, and I think it's, you'll see all those numbers a little bit different, but just to know, as they get bigger and older, the numbers come down, okay? And the blood pressure is going to go from 60 over 40 up to the normal 120 over 80. Quite incredible. So just to remember these things. We know nutrition, if you don't put gas in the tank, the kid's not going to grow, right? If you don't put gas in the tank, the car's not going to go. Nutrition is the most single influence on growth. What do kids eat when they're first born? They're just having breast milk and they're having formula for the first 6 months of life. And they eat. And then we're going to introduce some of their foods. And we're going to go into that more next week, okay? We know that, 1 second. So, sometimes children are the easy kid, and some kids are those easy, are harder, more difficult. They, don't want to go to other people. Remember, all children, all adults, everybody is different. All right, probably one of the most difficult things this week to look at is and you're going to get more of this next week as we go along, is theorists. Now, I'm going to send you some recordings on it. It's in YouTube. Freud, Erikson, Piaget, and Kohlberg. Those are the big four that we use. We do see a little bit about Fowler's. It's just all about, your spirituality and how that develops. But let's talk a little bit about these theorists. Now, these are these people who looked at children from certain views and figured out where they should be at a certain age. Now, Freud's all about psychosexual, right? So oral, anal, phallic, latency, genital. You can see how that relates, right? Psychosexual. So why is a baby oral at birth? Well, they only know to swallow and breathe, right? How do they soothe themselves? They put a pacifier in, right? Self-soother, put a finger in, a toy in, a rattle in, finger in, doesn't matter. The mouth is where they explore their whole world and how they soothe for themselves. Well, then why is 1 to 3 anal? Well, what do they do when they're toddlers? They potty train, right? So now it's all about, taking and controlling it. 3 to 6, they find out that they have different body parts. And that's what that phallic stage is about. And then it goes up to the genital again, adolescence. Now the hormones are raging, for girls, the girls, or girls, the boys, whatever it is, excited about, the person, the partner they want to be with. Now, Erickson, this is the most tested of all the theorists. And I'm going to try to make you understand what these things mean. And again, we're going to go over it again next week, but it's about psychosocial. It's about them in their world and the people around them. So, trust versus mistrust. Well, what does an infant need? Think about that. They want their diapers changed, they want to be picked up, and they want to be fed, right? So if you do all that stuff, they trust you. Well, what if you are in a family environment where nobody ever picks you up when you cry as an infant? It could be a drug abuse, could be just an abusive relationship, or it could be, many different things, right? But their needs not met, that is mistrust. So a baby who has trust is happy and healthy and is just, an easier child to work with. The one with mistrust, that's the one that's going to create more of that distance, that, not trying to cling on like the baby who trusts. Now, toddlers, what does autonomy mean? Autonomous, all about me, automatically mine, automatically for me, mine. So auto me. So all they want to think about is themselves. They want to do it. They want to try it. They have no filter. They don't know jumping off of a couch, jumping over to the chair that's too far away. They're going to land on their head and they're going to, get a bruise on their head. They don't know that. So that's the autonomy. Well, what is that shame and doubt? Well, when they're trying to jump off that couch onto the other couch and they're not going to make it, mom, grandma, or dad are going to be screaming, no, don't do that. Be careful. You're going to hurt yourself. And you don't let them try things. That is the shame and doubt. Okay. Sometimes children, you have to, unless it's going to hurt them, you're going to have to let them try to do it. Okay. Initiative versus guilt is your preschooler age. And this is they're trying to do things for you, but they can't do it all the way they should because they don't know how completely yet. And then it gets into more confusing. I think, and I don't know why they use industry versus inferiority, but think about a school age child. They do some things really well. There are some kids in school age that are good at math, good at spelling, good at running, good at swimming. That is their industry, their factory, what they produce, what they do well. That's an industry. Inferiority is those things they can't do, whether it be they can't run or they don't know math, but they want to do it all well. So industry, my house, my factory, what I produce do well versus what I'm inferior about, I can't do. And then, as I said, with your adolescence, identity versus role confusion. Think about what an adolescence is going through. Who am I? What do I want to be? And it's body image, body image, body image. So it comes into a lot of those things. Now, Piaget is all about thinking. So here we go. Sensorimotor. So sense is the touch, ori is the mouth, and motor is moving it. So it can be finding a rattle, then you do a little reflex grasp and you grab a hold of it, and then your hand moves and that rattle makes a noise. And you go, oh, I like that. That's learning. This is cognitive development. I'm thinking now. And when they grab that rattle again, they will move it to hear it. Then they put it in their mouth. They go, oh, I like that too. So this is learning. This is starting with no knowledge about anything and making themselves understand more and more. And as they get older, again, they're starting to see putting pieces together. By the time they get to school age, it's concrete. It's what they can see, feel, and touch. And then by the time they're adolescents, they can figure their way out of a paper bag and they can make mommy do anything they want them to do, because they could have not done well on a test but still go out Friday night because they know how to manipulate mom. They're so smart and they don't have to see it before. They can think these things up. Now, language development, we know it starts out with cooing and crying, right? They know how to get what they want. And this is the way that they communicate. Now, Kohlberg is another theorist, and he's all about right and wrong. So, and he knows that a right has a good consequence and a wrong is a bad consequence. And as they get older, from now, infants and toddlers don't really get this. This is more like your preschoolers and your school age up. So Kohlberg's all about your conscience, right and wrong. And as they get older, they know how to manipulate and say, well, I know it's wrong, but I'm going to do it anyway because I need to do it. So the benefit outweighed the risk there. Okay. That's Kohlberg. All right. And then what do kids do? From the moment they wake up to the moment they go to sleep, they play. Now there's all different types of play. So now you have to learn, what do these plays mean? We have socio-affective with other people, sense pleasure, that's like sand, gooey stuff in the fingers, like mushing your mashed potatoes on your high chair, right? That's the sense, the feeling. Playing in the sand in the beach, that's that sense. They like that. Skill play, maybe building a block. They can play alone or they can play together. And then we have these pretend plays or even dramatic that we're going to use in the medical, figuring out what happened, why they're afraid about stuff. Now, play is great and they need to do it and they need to be encouraged. Yeah, this little kid here in this picture got a little bit too much into the purple paint. But again, it's that feeling, that touch, it's sensory and motor. It's making them realize they can create like pictures with their hands on different things, right? And then they like the touch of it. And of course, it goes in their mouth. It's where everything goes. It helps with their intellectual. It makes them think. This is now their cognitive awareness, right? They're getting more alert. They're becoming social, creative, and they're starting to learn more and more. Now, the types of play here are important, and you should know them. An onlooker play is as simple as somebody watching somebody else play. Solitary play, I'm playing alone. Parallel play is toddlers, your 1 to 3-year-olds. They play next to each other, but they don't share anything. But they're playing next to each other, parallel to each other. They don't share. They're me, mine, mine. Don't touch it, and they rip it out of your hand. That's mine. So they don't share, but they're playing next to each other, parallel play. Then it goes a step higher, associative play. And associative is there's a whole bunch of toys and they're all playing with it, and there's no organization, which means there's not a winner in the end. And then and that gets up into your preschoolers, and then you get into the young school age and older preschoolers, and it's cooperative play. They play together with a goal, whether it's like playing a game of checkers or whether it's like building a tower with blocks and making a house when they're done. There's a goal. There's 2 or more children together playing with a goal. Associative, two or more playing together, there's no goal, all disorganized. Parallel, next to each other, don't touch my toys, as the toddlers say. Solitary, alone, and onlooker, I'm just going to watch. Now, these toys and what we do with them and that tummy time that we give those infants, it just helps them push and pull and roll and manipulate, and it really helps them. One of the things with playing and toys is something called object permanence. Children are smart. You'll show them a toy and they're going to remember it, okay, once they see it. And you could put it and hide it under something. And even though they can't see it, they're going to go back and find it. For instance, you get that little young kid, let's say a little boy has a car. And at nighttime, mommy puts that car into the toy box. That child knows in the next morning, he wakes up, goes to the toy box, that toy is going to be there. Even though it's not in sight, he knows it's there. Even young infants can do that. Put it behind something, they're going to try to manipulate and they're going to try to pull themselves there. Now, assessing children. Assessing children is multifaceted here. Number one, when we're looking at children, it's how do you approach a child? Well, younger children don't like nurses. I mean, we're that people that always have those needles, right? They don't want us around. So, number one, you've got to, first of all, get on their developmental level. You've got to break the ice. Whether they have pretty blue eyes, or you have stickers and give them stickers, or they've got a Batman t-shirt on, like, oh man, I love Batman too. You break the ice there, okay? And then you start, it's never a head to toe on a child. Never. It's usually focused. If a child is having a problem breathing, okay, it's respiratory, we want to listen to those lungs first. Listening and pulses and all that, pupils, whatever, can wait. But we need to do it when we can. It's not a head to toe. This is not adults, okay? Children that can't speak or like with disabilities, they do tell you through nonverbal actions what's going on with them. And there's all sorts of disability checklists that we can have there. We know children can be born with congenital abnormalities, from the cleft lip to club feet, there also can be syndromes, Down syndrome. I don't know if you ever heard of it, but Prader-Willi, Turner's, I could go on and on. The George, Pierre Robin. I mean, I could go on and on. Or it could be due to some sort of medication they took. I mean, I think today we're really more alert about mothers pregnant that they're not going to take any medicines until they check with a physician. Years ago, they didn't know it like that. We know there's our genetic things that go on. There are, like, for instance, Downs, it's a chromosome, it's something we'll be looking at. There's other ones as we go further, we'll be checking and we'll be recommended they do some sort of genetics before they have another child. All of these things can influence the birth of a child. Could be due to a lot of things, or it could be just due to those chromosomes. That Q22 pair of chromosomes could be DiGeorge syndrome. And if you have DiGeorge syndrome, there are certain things that you would look for, and you will see. Again, a nurse. A nurse is important. We are that person for education. That parents is going to look for you for support, and they're going to be yelling and screaming at you because they're tired, they're working, their kid's sick, got other kids at home. I mean, there's just so much going on, and sometimes a nurse just has to remember that, be patient. History and physical. Always remember HIPAA, even with children. Be very careful in children because at age 18, alert-oriented 18-year-old is going to sign for their own consent for emergency treatment. You must ask that 18-year-old if you can talk to the parents about what the lab results, etc. were, okay? Just be aware of that. An 18-year-old can sign for themselves. It's something I had to always keep reminding myself in an emergency room.
And anything under 18 they need their parents' consent, or we need their parents' consent, and we can talk freely
Right,
of it.
right, absolutely. Unless they're an emancipated minor, you know, with younger papers. Um, Also, if they're a parent that's underage that has a child, you have to speak to them. So there's so many different scenarios in pediatrics. You have to think about it. But yeah, right. It's which one do I worry about? When you don't know, you ask. That's what I've always learned. If I don't know, I'm just going to ask somebody. Again, talking with parents, parents want to give you a lot of information. We know sometimes it's just sitting there and listening. Um, and that helps. I know many times I would get a young infant in who is sick, and the parents have been in now, the doctor's 2 times in urgent care already, and they've been working, and the kid's only, 2 months old, and they're exhausted. Just saying to them, "Oh my goodness, you must be exhausted." And I said, "You have done such a great job with your child, and you're here now. We're going to take care of you." And you should see just saying those words that parents like, she understands because they're exhausted and they're trying the best for their child. Communicating with children, again, getting on their level, using play or where are your ears? Where is your heart? Where's your nose? Those sort of things can help you make you touching them less threatening. And I also would let them push every button that I could, whether it's on temperature probe or whether it's on a blood pressure machine, let them play. And let's say, oh, what number are you going to be? And these children actually do better when they're a part of the whole thing. So play, play, play. I went to work for 20 years playing, and I love that. History taken, remember, get that parent down to what's wrong this time. You're going to have some parents that want to give you a history of an 8-year-old from birth. And you don't all need all of that information. You need to know if there was anything like, were they premature at birth? That might make a difference. Or if they had some congenital defect, of course, that make it different. But a normal, healthy birth, an 8-year-old, what's going on now? And then we got to figure out, then let's, listen to their lungs or to their belly or look at their ear or whatever it is. Dietary history is important, especially if the kid is smaller. What do they eat? Allergies. Always knowing what medications they're on, of course. And immunizations are important. There are some parents who don't like immunizations for their children, and this can create problems for you as a nurse or other children that are very susceptible, that are immunosuppressed. So children upper respiratory, are your immunizations up to date? It could be something like pertussis. So you got to be careful. Again, looking at growth and development. And if this child's being admitted to a hospital, what are their habits? What is that pacifier they cannot live without? Or that blanket or that uh, doll or et cetera, et cetera. When you're talking to teenagers, sexual history can be a little bit tricky. You can ask parents to leave, and then you could get the sexual history from the parent. And you don't have to tell the parents what they've told you unless it's something that's going to hurt themselves or others. Okay. So sometimes it could be an adolescent with frequent urinary tract infections, right? A young woman. It'd be something, could be important information for them. Understanding the family and structure. You have some cultures that the father is the boss, that you speak to them, but don't touch them, don't look at them in the eyes. I mean, there's all sorts of things culturally that, I've always had to really think about. One of the things that I look at in children for their psychosocial is say, so how's school going? How are you? Who's your favorite teacher? What's your favorite subject? What are your grades? And they say they're B's. I'm like, oh, that's great. That's awesome. They're good B's. Which one do you like the best? And you're seeing how they're adjusting. Again, knowing any sort of habits that they have are important for you because parents can't be in there, 24/7. Sometimes they have to go get something to eat or step out of the room so we can step in. And then, of course, seeing the parent child, the way they work together. Working the last 10 years in an ER really was an eye opener for me. You have parents that would sit there on the phone and the children on the stretcher, and they're not paying attention. And the children on the stretcher are in getting those little black little ear things and throwing them all over the bed. And the otoscope is down and the drawers open and tongue depressors and alcohol pads are everywhere. And then mother's just sitting there and they're on their phone and not paying attention. So you can really tell a lot from this. How are they going to get that child to take medicines, et cetera, et cetera? Part of your admission should be their dietary. You have many cultures that don't eat meat, don't eat pork, don't eat beef, don't eat whatever, something that you need to know. And then some have conditions that they can't eat things like celiac, right? Any cultural food practices. And then sometimes we have vegetarians and they could be iron deficient anemia. Again, how can we increase the iron in their diet by still respecting their vegetarian diet? Get the dietitian in, right? That's why we have all these people. Again, physical assessment, it is not head to toe. That is for adults. With children, it's going to be as you can get them. If an infant is asleep on a parent's lap, I'm going to be listening to their heart and their lungs while the kid's quiet, for sure, for sure. All right. Again, getting that young kid ready for an assessment, getting on their level, breaking open the ice, having them touch and play with the equipment. This really decreases the level of stress, and just taking a little time decreases the overall time that you're going to be in there trying to get that assessment done. So which approach would be best to use to ensure a positive response from a toddler?
A.
Exactly. Never be up on top, tearing down at a child. You look like a monster. I would have them sitting on stretchers or the bed. I'd pull up a chair and sit lower them and sit there and just start to talk to them. And now I'm not threatening. So I'm a big woman. I could be very threatening, but I was not. I sat down and then it was great. Very good. So again, preparing the child. I can't tell you again, get below them, open up the conversation, start talking about maybe there's, the curly hair, their freckles, their blue eyes, the shoes, sneakers that are lidded up, whatever it is, get on their level and make them understand that you are not going to hurt them, and let them touch equipment that you can. I wouldn't put an IV needle there, but they can look at, the arm board, the tape, maybe the tourniquet, right? So again, getting them ready. When we do children versus adults, remember, children are smaller. Blood pressure cuffs go from a 00 all the way up to an extra large adults. And as you're grabbing that, you need to know what the age of the child is to figure out what cuff you can use. All right. Very important to think about. In infants, we measure abdomens and chest circumferences, and we also do head circumferences for many different reasons. So knowing how to do that and then documenting it, and it will tell us all sorts of information. Looking in their ears is up and down, out and backwards. Those things you need to understand. Again, when you're listening to the heart rate, do you know what the normal one is? Looking at the bellies, usually their abdomens are very distended and they're soft, right? As long as they're soft, you look at it first before you even touch it. Then you can, listen to it and then touch it. Genitalia, is it a boy or a girl? We're going to find out. There's times when they're both with some adrenal problems. So those things that we do look at. We're going to make sure they have an anus. There are infants born that do not have an anus. So it's actually, why do you think we do a rectal temp at birth? Making sure they have an anus. also to check an accurate temperature, but that's one of the reasons. Looking at the backs, looking if there's any little nodules in the low backs, looking for those little clues that could show us maybe there's a renal problem or something we need to do an ultrasound and check things. Looking for reflexes, all of these things. Remember, young children can't tell you everything that's going on. Sometimes you got to figure it out. Again, where to measure those things. One of the hardest things doing triage, which I did a lot of at this hospital, triage trying to get a height on a young child. They think that big piece of wood coming down is going to bop them on their head and hurt them. So now you got to make it fun for them. So I would go, okay, let's see what number we can be. Let me do me first. What number am I? I'm a number 7. All right. And I would say, I'm going to hold it. Oh, it touches there. It's good. And then I'd have them do the same thing. And they would do it, and not a problem, because they've seen what it looks like. It's not going to hurt. And then we make, yay, you got a number 5. What a great number. And they think it's fun. Again, play. Again, figuring out what's the proper blood pressure cuff. I actually like to do D on your toddlers and your preschoolers. I think putting it with that number A on the upper arm, I think it hurts. It pinches. I know it pinches me. So I can imagine the children feel the same. But you put them on their leg and you're distracting them somewhere else. They barely even know it's been done, and it is an accurate blood pressure. And the last chapter, all about pain. You're talking about pain, you're talking about children. Children do suffer because nurses are afraid to give pain medicine. I think it's been my pet peeve from working in the pediatric area. I don't think that nurses are comfortable giving pain medicines. I think that there's this misnomer they're going to get addicted with a couple doses of pain medicine. If I just had, surgery, ruptured appendix, I want something for pain. It's going to hurt. Making sure they get enough and that we don't wait too long in between. The Joint Commission has come up with a lot of things for pain because they saw it was a deficiency. And number one, they put your pain assessment, your number is part of your vital signs now. Every time you get your vital signs done, what's your pain level, right? And then they have the one where they go and they find out what's your pain. You do an intervention and you evaluate. It's called the PI, right? Your pain, you do your intervention, and you go back in 30 minutes and you evaluate, did it work? And now you have to evaluate, did the pain medicine work? It's all part of documentation, and it shows good care. Now, there's a couple different scales we use. I show you more of them, but I want you to know FACES, FLAC, which I'll show you, and numeric are the 3 ones that we tend to look at and we test on, all right? Now, FACES is that pictures below. It's from 0 to 10, just like numeric on adults, right? 0's no pain, 10's the worst pain in the world. Children ages 3 and up can do this. They say numeric, according to the book, starts at age 8. Not saying I haven't done it at an earlier age for smarter children, but it is 8 and up by the book. This FACES starts at age 3, and you show them the pictures and they'll point to exactly where they hurt. You know what the best thing about children in pain is? They don't over exaggerate. They don't lie. Adults are always a 10. How much do you hurt? Oh, I'm a 10. Oh, I'm a 10. Oh my God, I'm a 10. Oh, I'm a 12. I'm a 20, right? Children don't do that. They will put their finger exactly where they hurt. Now, as I said, numeric is for 8, and here's FLAC. Now, FLAC is for your 0 up to 3. Okay, at 3, it's now FACES. But young children that can't point to a picture and understand it, and non-verbal children. I've taken care of many a cerebral palsy child who is old, teenagers, and they're non-verbal. But you can tell by FLAC Their faces, their facial expression. Are they grimacing? Is that little chin quivering because they hurt so bad? Right? Their leg movement. Are they moving? Are they jerking? Or like they're so in pain they can't move? Their activity. Are they crying? And can you console them? FLACC. This is all what we do to evaluate pain, and it works well. It really does. I've worked very closely with that pain scale. So we also have other ones here, but again, faces is preschool, which starts at 3. Black is 0 to 3. Numeric is age 8. Now, acute pain could be due to many different reasons. You know, some younger children, they're going to tell you the location by banging their head or sticking their hands in their throat. Could be their ear hurting there or their throat hurts, right? They're going to do things that show you where the pain is. So then you go looking for it. I mean, it's easy if we have a medical procedure or an injury or something, we can figure that out. But sometimes it's the beginning of an ear infection and we don't know. So then we start looking and they start saying their ear hurts and you start looking. Just like adults are chronic, reoccurrent, persistent pain, you have children with sickle cell. They're going to have that type of things. You have rheumatoid arthritis. You have osteogenesis imperfecta, which is brittle bone disease. They're always breaking bones. So there's all different sorts of pains, and children have all of them too. If a child is always in pain, it's just like an adult, right? They're going to have problems moving around. They're not going to be emotionally happy kids, right? And they're not going to be able to function either socially or if they have to go to school because they're in so much pain, that's all they can think about. Again, any non-verbal type child, there are different sort of checklists out there. Some people, hospitals use them, some don't. It's finding out what your facility does use. And remember, culture makes a difference. I have gone into rooms where daddy's gone in with their son and they've broken their arm, bilateral, wrist fractures, the radius and the ulna are both fractured. And I want to give a little shot of morphine before they put a cast on. And they go, no, he's fine. He'll tough it up. He'll suck it up. He's fine. He's a man. And you're like, Dad, this hurts. This is not a man up thing. We need to give him something. Again, it's cultural. And I did find that a lot. And I even know my ex, who was Cuban, telling, our son, let's suck it up. It's going to be fine. Well, no, it's not. He needs something for pain. Okay. So just remember, culturally, they may say they're not in pain, but make sure they really aren't. Besides medicine, there's so many other things we can do. Now, I think the biggest thing in children is a distraction. You have a child, let's say they're mending from surgery, and you have them laying in bed doing nothing. All they're going to think about is their tummy. What if you give them an iPad or you turn on cartoons or music or give them crayons and something to color or a game to play or whatever, right? Play cards with them. That's a distraction. And that keeps them away. Remember, distraction always must be developmentally appropriate. What's ever appropriate for the kid. Playing a game, giving crayons wouldn't be for an adolescent. Maybe that one you want to go in and play a card game with, right? That one you could. Or get, child life or another person. There's always people in pediatrics that are extra that can help you with these things. If you as a nurse don't have that time to do it. Relaxation, look at this kangaroo care. How many premature infants laying on the warmer in their little isolettes and they're just moving and they're so anxious. Put them on mommy's bare skin and you watch all their vital signs relax because, that feels so good. And then mommy just stays there an hour. I don't care. They can stay there all night long for all I care. I'll talk to mom all night long with the baby so quiet, right? But it does work. And the last thing I'm going to mention about pain management is that non-nutritive sucking, a pacifier. In my research talking about children and pain, I found an article about a pacifier. and it was Harvard neuropsychologists, physiologists, talked about the difference between giving morphine and sugar water on a pacifier for procedures on infants, and they found no difference in pain relief. My grandson, at 1 month old, had a circumcision with sugar water and a pacifier. And the only reason why he cried is they didn't want to be held down, because they strap him down into this thing in order to do the circumcision. As soon as he was let up, he was fine. How many infants are crying? What do parents do first? Where's the pacifier? The self-soother, right? I like that word, that self-soother. Self-soothers are amazing. And for infants, they're my first line of defense when they're crying. Remember, there's not morphine, and morphine is used across the board in pediatrics. And it's one of the oldest medicines, but we know it well. We know the dosages well. So it's probably one of the safest pain medicines that we can give. But there's Tylenol. Tylenol works great on young infants. But they don't have much pain medicine ever given, so it works. Or your NSAIDs, your ibuprofens, opioids. We do have different things. Your PCA pumps on older children are great, that patient-controlled analgesia, where they've had maybe big abdominal surgery or maybe neurosurgery. They can click on that before they have to get a nurse to come and find out what's going on, and then go get the pain medicine, then bring it back. By that time, it's too far gone. They could just go click, and it does work well. It has to be an older child who understands what's about. And then sometimes, then of course, epidural, we do that in adults too. We talked about no pain, right? And atraumatic care. This little girl is smiling, and she's just about to get her blood drawn. And why is she smiling? That little white glob underneath that plastic thing is a numbing cream, and the skin is numbed. So when you stick the needle in, she's not going to feel any pain. So she don't care. Go ahead, take my blood. I don't feel it. Again, using things like this we use them for spinal taps, right? Works really well. Putting in central lines, using when we take ports and access them for things. These numbing cream we use a lot in the pediatric world, and it works well. Because again, remember, if you have a kid, if you're always pinching, always in pain, or whatever their condition, they are, psychologically, and they're not going to be happy. They're going to be angry children, and they're going to lash out at you, because children don't hold it back. Pain can be due to anything. Teething to immunizations. Immunizations, we can put numbing spray on there. We can put cooling on there. We can do vibration, buzzy bee things. All these things can help. Circumcision, I told you, that pacifier works great. And again, any sort of pain that children have, we need to address. And it goes on and on. It could be due to that, children get a lot of abdominal pain. That's one of the things they see. Or sickle cell. We do have young children come in all the time. And then whether we like to know it or not, we do have some children that are going to die, and they have a cancer and they're in pain. Making sure that they're getting enough medicine so they're just comfortable, so that their last moments will be comfortable. So, which of the following is an important factor for consideration and understanding the pain experience in children? What do you think?
B.
Absolutely. They're not going to tell you because they don't want a shot, or they don't want the medicine. They're afraid they're going to hurt them. Very good. Any questions? We're good so far, huh? Okay, let's go. Anybody ever do a cahoots before?
Yeah.
We're running really good on time today. Take your phone, put it on a picture on that little pretty thing up there, and push the website, and you're right to Kahoot. right, let's get going. Week 1. It's going to go by quick. I'm going to tell you it every week. From a worldwide perspective, infant mortality in the United States, what? Is it good? Is it bad? Remember, when you talk infant, it's the first year of life. So how many children die from a worldwide perspective? It's one of the highest, believe it or not, as compared to other countries. And you'd be surprised with that, but we're not up where we should be yet. Although many, many changes have been made and I've watched them. The leading cause of death from unintentional injuries in children is, and this is some unintentional injuries or injuries that happen that somebody didn't inflict upon them, okay? And the one thing about children and all ages of children, the one thing that is the biggest fatality is motor vehicle. Whether it's the infant that wasn't put in the seat right, they weren't put rear facing for the first 2 years, with the weight the way it should, or it's a teenager who now is driving the car. So now it's motor vehicle related injuries. So motor vehicle, whenever you see an answer about unintentional injuries, it will always be your answer. What statement is most descriptive of pediatric family-centered care? So family is the constant. We're going to start discussing next week. We're going to do infants and toddlers and preschoolers. And we're going to show you how, at first, what is a family, an infant? No, it's basically home and family. As they get older and get into school and then getting friends, they start to learn other families and break away from the tight knit of family. But, in any child, the first and their basis is their family. It's the only constant they have. They always go home, hopefully. The major cause of death for children older than 1 year is dive bombing, right? Off of the couch, onto the other couch, missing it, hitting the floor. So yes, it's unintentional injuries, whatever that may be, okay? So children older than 1, we are protecting them. Remember, they're autonomous. We need to protect them, but we need to let them explore also, okay? It's that fine balance there. The nurse caring for the child in pain understands that distraction Remember, distraction only works if it's developmentally appropriate for the child, okay? If it's too much, they're not going to understand it. It's too little, they're not going to understand it. Again, it must be appropriate for the child, and then you could distract them. Because what they do is they stop thinking about the pain and their attention focuses on something else that they want to do. I mean, give a kid an iPad and let them play, on a Switch or whatever. They're not going to think about their pain anymore. They're just going to go Roblox and they're going to whatever, right? I know my grandson would. In what type of play are children engaged in similar or identical activity without organization or mutual goals? Remember, there's certain plays that I told you. We had solitary, right? We had onlooker, we had parallel, we had associative, and cooperative. And as they go up, it's more interactive with another. And it's called associative. Parallel is played next to each other, but they're not touching each other's stuff, right? Now, they're engaged in similar or identical, which means they're playing with the same things. That is the associative. No goal. Cooperative, there is a goal. Which statement best describes the process of critical thinking? Remember, critical thinking, it's purposeful and it's goal directed. You know, we think that critical thinking is this big thing. I mean, think about it. What are you having for dinner tonight? Are you going to go out and buy it, or are you have to go to the grocery store and pick it up? And you're going to pick up only what you need because you know what you have at home. That's critical thinking. You get this much for your paycheck. You know what bills you have to pay and what you can't. That's critical thinking. You needed to get to class today. You needed to go find the Zoom number. That's critical thinking. Critical thinking we do every day, all the time. What is probably the single most important influence on growth at all stages of development? Nutrition, nutrition, nutrition. If you do not fill the tank with gas, the car won't move. If you do not feed a child, they cannot grow. And cognitively, they will be delayed. And even in their growth and development, it will be delayed. They're not going to be able to lift their head up by 3 months if they're not eating. They're not going to be able to turn over completely by 6 months if they're not eating. They're not going to understand to have a a reflex grasp or a voluntary grasp. They're not going to know anything without the fuel to make themselves think and to grow properly. Nutrition, nutrition, nutrition. You don't eat, they're not going to be where they need to be. They will be delayed. Frequent developmental assessments are important for which reason? If we know what's going on with a child and we can see that they're rolling over when they should, sitting up when they should, we know they're on the normal track. But if we see a child at 7 months old who still cannot hold their head up, which should be done by 3 months, we know that we need to institute an early intervention, which is physical, speech, or occupational therapy, or all of the above. Okay, so as soon that we can get early intervention, the quicker they'll catch up. And as I said, that's the beautiful thing about kids. They catch up really quick. So we got to get that intervention in quick. Which function of play is a major component of play at all ages? What's play all about? And it's called the sensor and motor. It's play is all about touch. So the younger kids are the oral or the motor is playing with them. It's that activity. And it's part of cognitive development in the younger kid and even as you get older. 3 children playing a board game would be an example of what type of play? And that is cooperative play. Really good. A board game, there's a goal. Somebody's going to win, and that's why it's cooperative. If they were playing together with no goal, that's what associative is. The head to tail direction of growth is referred to as. What this means is they start with first moving and having head control, neck control. Remember at birth, their heads, they're floppy, right? By 3 months, they should hold their head up good. By 12 months, they should be attempting or walking at that point. And it's called cephalic, cephalo, head, to feet, tail, which is caudal. So cephalocaudal is head to tail, okay? Does those words now make sense to you? What is the single most important factor to consider when communicating with children? So when you want to talk with a child, make sure you're on their level. Perfect. Very good. What 2-year-old child pain assessment tool should the nurse use? We've talked about FLAC, we've talked about faces, we talked about numeric. 2-year-old is which level? And 2-year-old is still FLAC. Okay? You do not get to faces till they're preschooler, which is 3 years old. Okay? So 0 to 3 is FLAC and nonverbal children. At 3, it becomes faces. And at 8, it becomes numeric. At 6 months, an infant's birth weight should do what? So by 6 months, it should double. Very good. Now, what happens if it doesn't double? What if it's, tripled by 6 months? Well, that's too much weight, right? Let's evaluate nutrition again. Well, what if it hasn't doubled? They're born and they're 7 pounds and it's 6 months and I only weigh 9 pounds. Well, now you're going to evaluate we're not putting enough gas in the tank, right? Probably cognitively and developmentally, they're not where they need to be because we're not feeding it. So, what can we do to get that nutrition to that child? So, these are things that we look at so we can do an intervention in case they're not where they should be. The first expected fine motor developmental milestone for an infant begins. Again, we're going to go more over this next week. I've mentioned it a couple times. When we talk Palmer's about the hand. So the first thing they do is you put the rattle or you put mommy's finger in the hand, and that baby by a reflex will go around and grasp it. And parents go, "Oh, look, he's hugging my hand. Isn't that wonderful?" Well, you're not going to tell them it was a reflex because they think the baby knows who they are, right? Well, then it comes to the point where the rattle comes around and they grab it, and that's the voluntary. Then it goes to the point where they're in a high chair and you put little puffs there or Cheerios, and they could take finger and put it into their mouth, right? Well, it starts out with like their whole hand and smush in the mouth. Well, it ends up with either their thumb and their finger one at a time. They can do it. That's the neat one. Then it goes up to the point where they can put things into a container and then build a block of two. It's part of the reading that will go on for next week, all about fine motor development. And remember, fine is F for fingers, what the fingers and hands do, okay? And then there's gross motor, G, get up and go, 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 movement, all right? So there's fine and gross motor. An 8-month-old infant should be expected to perform which fine motor developmental skills? What do you think? Well, they usually start putting stuff in a container about 11 months, and they build the blocks tower 2 by 1 year. So it's somewhere before that. It's that they can grab the rattle and they could do either a crude pincer grasp. Some kids might have more of a fine, but they will absolutely be able to grab that handle and do that crude pincer grasp. The natural physical developmental sequence that most children follow is what? This is that gross motor. That's movement. What does it start with? So we know that it starts with their head lifting, right? That's the first thing they have control over. Then they're on their bellies and they go from their belly to their back. Then they go from their back to their belly. Then they get up onto their knees and they crawl actually backwards first, then forward. Then they get up to somewhere and they climb up and they creep around on their feet and then attempting to walk or walking by 1 year. Remember, all children are different. There are children that are walking by 7 months and some other children who are not going to walk till 15, 16 months. All my children didn't walk at 15 months, at 12 months. At 15 months, they were running. They never walked. But this is children and the way that they do. So remember, all kids are a little different, but there's certain things, as long as they're moving in the right direction and they're making progress, that's the developmental things that we look for. Which behavior indicates that an infant has developed object permanence? This is one of the concepts that loves to be tested. I don't know why. It's just one of those things that I see on quizzes, exams, and HESIs. And basically, object permanence, that means the object is now permanent, which means they know it's there whether they can see it or not. Whether you put it back in the toy box or you put it underneath a blanket, that child will go search for it. They know it's still there and they'll still look for it. Very good. In general, an infant should triple their birth weight at what months of age? And that's at 12 months. So born at 7 pounds, at 6 months, they're 14 pounds. And by 1 year, they should be around 21 pounds. Again, why do we want to know that? If they're too much or too little, we need to do some sort of intervention to make it better for the child, okay? Perform a head-to-toe assessment on a toddler. Most important to consider before beginning this examination. Remember, toddlers are 1 to 3-year-olds. So again, prepare that examination based on the child's developmental age. Remember, you need to get below them first. You need to break the ice open so that you're not threatening, and then you base it on their stage, on their age. A toddler, so where's your ears? Oh, which ear you tell me is hurting? And they'll show you which ear. Or, where's your nose? And this now becomes fun. I mean, I never did a day of work without stickers in my pocket, whether it was princess stickers, SpongeBob's, Spider-Man, Batman stickers. I always had stickers on me. And those children their faces light up with just a little sticker. I don't know, something they love. According to Piaget, toddlers are in the blank developmental stage. Remember, Piaget is all about cognitive development, figuring things out, thinking. And it's all about sensoromotor. It's all about understanding the taste, the texture, the movement. It's taking that rattle and then grabbing it and going, oh, that's good. Oh, I shaked it. There's noise. Oh, I put it in my mouth. Oh, that feels good. It's learning. It's making those little blocks and learning this part. And then, oh, I can do this now. Now I can do this and building more upon that sensory motor. All the rest are actually, we talk more about your Erickson. And then formal operation is, the biggest of Piaget, where they can think, an adolescent can think their way out of a paper bag, as I call it. Adolescents know how to think. Which intervention helps a hospitalized toddler feel a sense of control? Again, I think toddlers are the hardest group to be hospitalized, you know, and be hospitalized. Their age is 1 to 3, and they're used to mommy and daddy, aren't they? The other thing that they like is they like their routine. Trying to get the same foods if at all possible. Same time for meal times if at all possible. Um, Bath time, nap time. All of these things make a toddler feel a sense of control. I mean, I've raised children, plus I've helped raise my grandson who's now 7. And the one thing I could say is if that kid was on a routine, the happiest kid in the world, take the kid, take them off the routine, and these children, they don't know when to sleep and they're cranky, right? And they do the same thing in a hospital. Because remember, we're just always there touching them, feeling them, squeezing with blood pressure cuffs and sticking them and laying them down and holding them. And so anyway, getting them on the routine. And then number one, if we can have those child have the parents stay there is part of it too. But it's the routine that's the biggest one. And if we can't require parents, that's one thing we can't. If they can stay, that is the best. All children reach developmental milestones at the same age. Absolutely not. They're all different. I've had some of my friends' children at 7 months, they're walking, and they're looking at my kids, and they were 12 months and they still weren't. And I'm like, okay, whatever. Now, they're all smart children, really, came out well in the long run, smart at school. It was just they do things different at their own pace. Immunizations for a 4-month-old infant, which action should the nurse take to provide atraumatic care for the infant? We're about to give usually 3, 4 injections, right? At 2, 4, and 6 months. Your immunizations. How do you do atraumatic for that? As in less painful. And that's giving them little sugar water on a pacifier, and it's just like giving them morphine. It's quite crazy. I read that article and still in amazement about it. But it works. I've put it to test many times. Which of the following immunizations can be administered to a newborn? Now, in chapter 31, all about infants, you're going to have this double page of immunizations. You need to know basically the first ones we give. And then knowing at 2, 4, 6 months, 12 months, 15 months, and 2 years, we give certain things. And we'll be going over those, what you need to know. But it is Hep B at the hospital, usually before they come home. Now, on occasion, they'll do it at the first doctor's visit. And it's usually something to do with insurance, where they won't pay for it until the first physician visit. So sometimes you get into that with insurances. The normal heart rate for an infant is. And that's 140 to 160. Respiratory rate, 40, 60 at birth. Yes, and then it comes down slowly as we go along. Very important thing as we're measuring things like we're going to give digoxin. If they have a fever, is their heart rate elevated? Dehydrated, is their heart rate elevated? In pain, is their heart rate elevated? These things are important to know what the normal numbers at what ages are. What is the preferred site to give an injection to an infant? You learned this one in pharmacology. And the way that person is giving an injection, I would never do that to an infant. That kid can pull that needle right out and scratch that whole upper thigh. It's called vastus lateralis, okay? Vastus lateralis until they're up and walking. And then they'll do more like into the deltoid, okay? The death of an infant under 1 year old with no known cause is called what? And thank goodness we've decreased the incidence of this by actually just making sure they're on their back all the time. We call it back to sleep. And that's caused SIDS death. With SIDS, we're going to go over it more next week. Remember, it's all about putting your infant to sleep on their backs, not on their tummies. They feel on their tummy. If they vomit, they could inhale it, aspirate it, and then they couldn't breathe. And then even on their side, they're inhaling, could be some of the vomitus, but also the carbon dioxide. They could breathe it in, and that could cause death also. So sudden infant death, put them to sleep on their back. And actually the one thing that you could decrease the incidence is to breastfeed the infant. It's the best thing you can do for an infant. The Vietnamese mother of a child avoids eye contact with a nurse. Considering cultural differences, why doesn't she look at her eyes? What's that all about? Again, I told you, understanding culture and who you're working with can help. And I always found if you ask the person why, they are pleased and really glad to tell you the reasons why, because it makes them feel like you really care to ask a question. And it is respect. That's all it is. It's respect. They won't look at you in the eye. It's just like some Middle Eastern cultures, the men who want report given to them. You can't touch them and you shouldn't stare at them in their eyes. It's just culture. So understanding it helps you give better care for your child because you're respecting the parent. A child from Mexico is hospitalized for a serious illness. The father says the child's being punished by God. Why is their parents Why is the parent saying that? Why are they being punished because they're hospitalized? And they have a common belief in this culture. This is all about. I mean, children themselves, up through even preschoolers, believe when they get sick, they're being punished because they did something wrong. Toddlers don't get it, but in the preschoolers and even into the school age children, they feel that they hit their brother yesterday or they failed their math test. That's why they fell down and broke their arm. They feel that they're being punished. In the Mexican culture, it's globally that they believe that they're being punished because they're sick, because they've done something wrong. Which term refers to an individual's life when he or she is more susceptible to positive or negative influences? And that's one of those definitions that I was looking at before. And that's called the sensitive period. What is characteristic of the pre-operational stage of cognitive development? These are ages 2 to 7. Are these children logical? Is their reasoning inductive, generalizations, or their thinking is concrete? And the answer, thinking is concrete. Now, how can I make that understandable for you? If it's concrete, it's there, it's hard, it's solid, you can touch it, you can feel it, you've seen it before. That's where their thinking is. If they've seen it before, they understand it. They're not logical. They don't think, they can't build upon that. They don't make any generalizations because they don't even know. But if they've seen it, touched it, felt it before, they can think it and figure it out. Okay. And last question. According to Kohlberg, children develop moral reasoning. What is the preschooler stage of moral development? Preschoolers. Moral development, Kohlberg, what is he all about? Actions are good or bad, and in terms of their consequence. So they can good or bad, and all of them have a consequence to them. It's all about right and wrong, okay? And we know that as the kid gets older, the kid will determine, yeah, I know I shouldn't do that, but does the benefit outweigh the risk here, or the punishment for it? So this is Kohlberg, all about morality, good and bad. Reward and punishment. Number 3, Tristan. Good job, Tristan. Number 2, Desiree. Good job, Desiree. Number 1, Veronica. Good job, Veronica. All the way through. Emma and Salma. So I'll be doing Kahoots every week. If I can't get to them, they'll always be sent to you. Again, as you can see, they all will go back and it will look at what you were, studying in, through the lecture. And I think it's a good thing to go back and to revisit it, and it can help you understand things. Anybody have any questions, comments, concerns? The one thing I want to tell you is this discussion question, remember, it's twofold. Tell me about you. And then number 2 is all about nutrition. And you need to do it in APA. I need a reference and cite in the paragraph where that reference came from. Okay. If you have any problems with APA and you can't, let me know and I can help you with it. I will put little examples there. I always will write something. If you get less than less than a 20, go back and look, and it will tell you what you needed to do to change it to make it better. And a lot of these discussion questions are things I don't go over with in detail, but you're going to see on exams it has these. Okay, so It's been a great class. I told you we'd be done a little bit on time. We're right there. So you all have a great first week. Anybody who came in late, don't worry, it's understandable. And I'll write that notation down for you so it's known, okay? Thank you, everybody. Nice meeting you. Anything you need, remember, I need to know accommodations for anybody, all right? And again, communicate. If you can't, let me know. I can help you before something happens, not after, okay? Have a good day, everybody.
Thank you. Question real
You're
quick.
welcome. Sure, go ahead.
My module hasn't transferred over from the Wednesday class to your class. When's the discussion post due?
Wednesday night.
Okay.
The initial.
All right. Thank you.
You do have to redo the initial technology quiz to get into my shell. That's the one thing I can't change. But the discussion, if you had like already done it, it's like at the end of the week, I'd say, all right, don't worry about it. But it's not Wednesday yet, so I don't know.
Okay. All right. Thank you.
You'll be good.
So, is everybody from the Cookville campus officially in your class? Because I know we were having some
I know
technical
Dean Litteral
difficulties.
said there was 9 of them to come in. No, I already spoke to Dean Litteral. He came on. I spoke to him.
Okay.
Okay.
Yeah, there's just 9 of us, so that works out good.
No. Yeah, there's 9 of you. I know. Because he said, yeah, there was 9 spots. Put them in Bogart's class. Okay, this is not a problem. I don't mind. I work with Cookville all the time and him all the time. We've got a really good relationship. He's a PEDS person too, so it's
Yeah.
not a big deal. Yeah. And I will. Now I have to put your time that you came, but I put in there just registered. It's not going to count against you.
Okay, yeah,
Don't worry about that.
I signed on to Morris's before I came here because that was who I was supposedly in, and then she said I wasn't in there, so I just came here.
It's not a problem. Not a problem. You were somewhere. Don't worry. And I can validate that for you if you need to, okay?
Okay, thank you.
You're welcome.